My name is Professor Head, Department of Pathology, Dr. Ram Manohar Luhia. Cytology by Dr. Kamal Mehrbanu. And the session. Over to you, ma'am.
So a very good evening to all of you. Special thanks to Dr. Sumit Gujral for your invitation, to Dr. Borges, and to Dr. Dhanashri, and also to Dr. Apurva for actually moderating the session, and to Dr. Sneha for staying back. And she's on her way for a trip, and she's taking out special time to be here. So a very special thanks to her to be the expert on the forum. So without much delay, we will start the talk. And as the topic has been introduced to you for today, this is we are going to be talking about screening for cervical cancer. So just before I get to this, we should actually just, to be more clear, call it screening for cancer of the uterine cervix. Start with a joke. We'd actually given this as a topic for a short note to our MBBS students, and half of them wrote about, some kind of screening that they were doing for lymph nodes in the cervical region. So being more specific, we're going to talk about screening for the cancer of the uterine cervix. Okay. At the outset, I have no conflict of interest to declare. This talk is going to be talking about several methodologies, about methods for computer-assisted screening, about HR-HPV screening, and so forth, but I do not endorse any of these in particular, and you can use anything that is kind of approved for usage in the lab for diagnosis. So what will my talk cover? I will be telling you a bit about the magnitude of the problem, about the screening strategies that are available with us, the pap smears, the HPV screening, the HR-HPV, colposcopy as in VI and villi, which is being used more extensively in screening programs in India. We will also take a look at prevention with the HPV vaccine. The treatment options, not per se for the cancer as such, but when you're looking at the screen and when you're getting those pap results, or when you're giving those HR-HPV results, what are the options that are there for the gynecologists who are treating these patients? Or in other words, what are the protocols out there? We will not get into details, but just get an idea about the implications of our results. And then we will try to look at the need for the screening, or it's obviously there, and the controversies that are associated with it. So I need to stick to my time. We'll finish in the next hour or less. So I will go just be talking about what's more important on each of the slides. And I would like to emphasize here that cervical cancer is one of the highest mortality cancer in women worldwide, and that India contributes to about 1/5 of the world burden. If you actually look at this map here, you have a light yellow, which is kind of getting into the lower incidence rates, which, maybe because it's a little less reported. But then if you look at the mortality due to this lesion, it's kind of still getting higher at whatever reported rates are there. So obviously what we are doing is we're not screening correctly, and maybe we're not providing enough treatment to prevent the mortality in this cancer. So what we need to target is both the screening, the prevention, as well as providing enough centers with standard protocols for treatment of cervical cancer. So if you look at this map of India, this basically denotes the results that are coming from hospital-based studies at the ICMR center, and we know very well that we have like a fair number of centers in Assam. So maybe the intensity of the colors out here actually denotes how much this is being reported, and maybe UP Bihar and does not report enough, or maybe does not have enough registry numbers coming from here. And Jammu and Kashmir, as we can see here, doesn't have much tumor. There can be two reasons. One, of course, is the less reports that are coming from there, and second is because this is a sexually transmitted disease, and the practice of circumcision apparently in Muslim males may result in less incidence in the uterine cervix. But I usually don't like to say this because it does occur across Indian women, and therefore one should not think for any reason that one is protected from having this malignancy. Coming to the predisposing factors, the human papillomavirus definitely accounts for almost 95% of the cases, and coexisting sexually transmitted diseases can be present, and they say that maybe the presence of herpes along with HPV may kind of increase the predisposition to the malignancy. We also need to understand that all cases infected with HPV are not going to develop the malignancy. There will have to be a persistent infection maybe for 10 to 30 years before there is a transition of the cells from non-neoplastic to neoplastic cells, and then increase in the stage of the disease. So how does this HPV act? Basically, it is the HR-HPV or the high-risk HPVs which are causing the malignancy. And among them, the 18 and the 16 are more common. You have 45, you have several others, you have the 31, 33, 35, and so forth. And interestingly, they have been divided actually into groups, and you have like a group 1 and a group 2. And in the 2, you have a 2A and a 2B, and I'll come to that. How does these HR-HPV, they act? They act by producing these oncoproteins, which start getting produced pretty fast, which is the E6 and the E7. And they, if you just want to remember in short as postgraduates, will be acting through the P53 pathway, and they will be acting through the retinoblastoma gene pathway. And through both these pathways, they basically cause the enhancement of the CDKN2 gene, and thereby they cause an overexpression of P16. So you have the viral E6 and the E7 protein, and then you have this CDKN2A tumor suppressor gene, which is kind of triggered, and then you have an overproduction of the P16. So why I'm telling you this is that these are then the diagnostic markers that can be used in order to detect whether HR-HPV is present. So your kits may depend upon using either these viral E6, E7 protein detection. It may be looking for some very commonly earlier also you must have seen, you do like a P16 IHC to determine whether this epithelium is getting neoplastic or not. And then you can also look at directly the DNA, you can look at the RNA, and various hybrid capture methods are also used for detection of HR-HPV. So when you look at carcinoma cervix per se, what are the types of malignancies you can get? They are epithelial tumors, which can be either squamous or glandular. Now, in the squamous, we prefer now not to grade as CIN 1, 2, and 3 in cytology, but it's rather a low grade or a high grade squamous intraepithelial lesion. And you also have these various subtypes. Let's not get into the details. They're basically morphological subtypes with no great implications per se as far as prognosis is concerned. But in the adenocarcinoma group, you have the classical endocervical adenocarcinomas, NOS, which are HR-HPV associated. But please note that you also have certain subtypes like the gastric type, which are not HR-HPV associated. And that brings up the discussion of whether just using HPV screening is going to be able to detect all your tumors of the uterine cervix. So coming to the screening of the uterine cervix, cancer of the uterine cervix, what are the possible models that are available to you? One, which is the conventional, traditional, old model, which is the cytology model. And as we all know, this model uses the pap smear. And the pap smear can be either a liquid-based cytology, or it can be, just let me try to get the pointer. Okay, great. So It can be either liquid based or you can do a conventional smear. The pathway that is being propagated now and kind of has a higher sensitivity and maybe it's more effective, easier to collect, easier to do, would be the molecular model where you do the HR-HPV testing. And this has been advocated to start from 25 years of age onwards, whereas the cytology is classically done between 30 to 65 years of age. And then you have an ideal model where you would have, highest penetrance, where you would do both the HPV and the PAP together, and this is known as co-testing. So often in the exam or otherwise, people may ask you, what are the modalities that you can use and what is reflex testing and what is co-testing. So co-testing basically means is when you're doing both the HR-HPV and the pap smear together. And the reflex HPV testing is when you're doing the cytology first. You're getting anything above or something like an ASQS above, and then you do an HPV to reconfirm that your ASQS is basically associated with the HPV or it is not associated with the HPV, because you know that AS can occur because of other conditions as well, and we'll come to that. So coming to the pap test, uterine cancer this was advocated way back in 1928, and unfortunately, like a lot of good work, this lay in the in the bounds of the journals, and actually into clinical practice this was put into somewhere in the 40s. And in the 40s, people then started doing scrape smears from the uterine cervix and started using the pap stain to differentiate the superficial, the intermediate, the parabasal cells, as well as to detect the malignant cells in these smears. And this smear was then very much advocated, and a lot of the so-called developed countries practice this, and we can see in the graphs that are there of their incidence that with the use of pap smears the incidence actually went dramatically down. So we know very well that the cytology model is a good model. We will come to the problems that are there with this model as well. So from a pathologist perspective, you can do either a conventional smear or an LBC smear. In a conventional smear, you just spread, kind of roll you collect with the brush. You know that you have to address the endocervical junction. So you make sure that you visualize the uterine cervix, you insert the brush or the IR spatula or the whatever you're using for collection into the os, and then you rotate it. You collect the cells on the brush, you roll it on the slide, and you stain them with a pap smear to be able to see the cells and detect whatever you're seeing there. Then the LBC is a liquid-based cytology method. A lot of you must be aware of it. You again use a brush to collect. You insert the brush in the vial. You kind of whirl the brush around, make sure the cells get into the vial. You can use either what is classically available, either a thin prep or a short path, and now there are a lot of other systems available. But the thin prep is basically a membrane-based system wherein the cells, they are kind of cleaned up into a membrane, which is then imprinted onto a slide to get a very clean smear. And the short path uses a centrifugation followed by a sedimentation method. So there are various methods by which you can clean up your background and get cells out there. And these smears are then usually of a limited size, easier to screen. So see, this is how you will collect. You have to visualize the os. You kind of insert the brush. It can be an IR spatula, a brush of this type, or a brush which is available with a thin prep, which is shaped like this, which scrapes both your endocervix as well as the ectocervix, and then you kind of push the cells into the liquid or smear them. So this is basically to show you collecting a good smear is primarily important in order to get a good report. So your report is as good as the collection, I seriously believe. And this is basically what the short pad does. So this okay, that one is this what the sedimentation, and then you're doing sort of a sedimentation onto the slide, and the top is what the thin prep does, is it kind of filters the cells onto a membrane and then imprints the membrane onto the slide. So what you can do subsequently is you can do a manual examination of the smear, whether it's a conventional smear or an LBC smear. But you also now have AI-based systems which can be semi-manual or totally automated, in which you can screen your smears. And like we have the system from Hologic, and this screens the smear and it marks about 21, 22 areas which are looking doubtful as per the AI software. And then you have to go through the smear in just those 21 areas and be able to say whether there's any malignancy there or not, and which where in the Bethesda classification does your smear lie. So as far as the reporting of the pap smear is concerned, for us, we use the Bethesda system, and the Bethesda categorization, it can be either negative or you can have an epithelial abnormality. The epithelial abnormality is further categorized into squamous or glandular, or it can be either you seeing endometrial cells, and in any woman above the age of 45, you have to comment on the presence of endometrial cells in your smear. So before we go to the look at the cytology, I want all of you postgraduates to basically understand that when you're doing the smear collection, what you're trying to target is this transformation zone. And most of our malignancies or the pre-malignancies, the pre-cancers, they tend to arise in this transformation zone. And this transformation zone should be well visualized in biopsies as well in order to look at whether it is getting affected. Now here you're looking at basically a low-grade intraepithelial neoplasia, and you can well visualize these coilocytes. See, evacuation in the squamous epithelium is present even in the normal epithelium. When your nucleus is in the center and your nucleus gives you a kind of resinoid feature, is when you suspect that you're getting what are known as coilocytes. And these coilocytes, as you can see, they are a product of the HPV infection that is occurring. And at the same time, if this nuclear changes, which are occurring right from the base to the top in this case, you would grade this as high grade. And if your changes are confined to the lower half of the epithelium, you would grade this as a low grade lesion. And when these cells, they infiltrate into the underlying tissue, you're going to be looking at a invasive squamous cell carcinoma. The adenocarcinoma in situ will be visualized something like this, where you're finding dysplasia. The glands will tend to become a little more angulated. You might sometimes find, secretions with neutrophilic infiltrates inside the glands. You will find sort of lobulations of those glands that are present. At places you might find multilayering of the nuclei, and if you look carefully, you will find mitosis, which may be present in the superficial layers of the epithelium. So if all that is present, you may be suspecting. And when these glands, they kind of open up, you have more of the inflammation in the lumen. They are more angulated, and they're also present around the larger vessels in the stroma. So you should be careful. If in your biopsy you're seeing these glands around the larger vessels in the stroma, you should kind of think that these glands have gone deep enough. And sometimes these glands may not look so malignant, but if they've gone really deep enough, then you need to suspect that there may be a malignancy that may be present there. And you look for dysplasia, look for changes, and you come to your diagnosis finally. So this two-tier grading system is preferred these days, both in biopsies and in cytology. And let us see what you will see in cytology. So in a cytology smear, you will be seeing the superficial cells, you will see the intermediate cells, and as I said earlier, this pap stain is a differentiating stain, so it kind of gives you this pink hue to the cytoplasm of the superficial cells, a green hue to the intermediate cells if it is a well done smear, and it gives you these are your endocervical cells which form these kind of clusters. And in endometrial cells, you will find kind of 3D clusters and sometimes what is known as a top hat appearance, which will be present. So these endometrial cells, as I told you earlier, need to be commented upon, especially in women above 45 years of age. So what are the epithelial cell abnormalities? They can be atypical squamous cells, which can be either as US or undetermined significance or as H. Now, given a choice, of course, one would prefer to have an ask US. Why? Because when you have an ask edge, it is a possibility that HSIL may be present in the patient at some place, and maybe you haven't got it. So there will be a protocol wherein you will have to repeat the smear in order to rule out the presence of HSIL in cases which are showing you ask edge. And as I said earlier, you might also want to do a reflex testing if you have not got the HRHPV test done. So in a low grade, so you then go ahead to a low grade lesion, to a high grade lesion, and then to an invasive squamous cell carcinoma. So when you say ask, what are the features you can look at? They can be multinucleation. They can be increase in size of the nucleus. And when you look at the increase in size of the nucleus, this increase is usually 2.5 to 3 times that of the intermediate cell. And when you look at the ask H, this is going to be a much larger nucleoside ratio, but the size of the cell, unlike here, where the size of the cell is kind of large, the ask H, the size of the cell is kind of smaller, something like those metaplastic cells that you see. And the nucleoside ratio is really high. There will be a post clumping of the chromatin, and there will be an irregularity of the nuclear membrane. Also note that this ask H may be a feature of, maybe atrophy sometimes, maybe post-radiation changes. So you need to have your history right. If your patient is postmenopausal, think of atrophy also. And in a lot of cases where we suspect either an SH or we're thinking HSIL, but there is a background of atrophy, it may be a good idea to treat the atrophy first and then go back and do a smear again to make sure that you're not missing out HSIL. So as you can see here, this is another cell. If this was live, I would have asked you, but this is probably another SH that you're seeing here. You can also appreciate another cell here. So this is what you would be looking at in an SH. Now, we did talk about reflex testing. The point is, what I'm trying to show you here is that there have been studies which have looked at, a mismatch between the HPV and the cytology. So please remember that in real life, this can also happen. So you may be very sure that you're looking at an SH or you're looking at an HSIL, and yet your HPV may turn out to be negative. There can be various reasons for that, and the most important reason is that is sampling. And the second one is, if it is the sensitivity of your test per se. So no test we know is 100% sensitive and specific. So it's quite possible that you're missing it out because of the sensitivity of your test. So these discrepancies in the HRHPV and the PAPs do exist, and that is why, as I said earlier, the penetrance of having a co-test is always best, where you're doing both the PAP as well as the HRHPV together. So when we look at the low-grade squamous intraepithelial neoplasia, here you can see the nucleus is large, and I like to tell my residents that if you look at the size of an intermediate nucleus, it's about 8 microns. So that would be approximately the size of an RBC. So if you're seeing RBCs also in the smear, and you put those RBCs on your nucleus, you can be accommodating at least 3 RBCs in the length, and then you know that you're probably looking at a nucleus which is larger than it should be. And if you're it's a happy situation, then you've got also the clearing around this nucleus, and maybe sometimes you've got this kind of a racinoid look with some irregularity of the nuclear membrane and some clumping of the chromatin. In that case, you're sure that you're looking at a case of LSIL. So those are the features of LSIL. Now let's wake up and do a poll question. When you move to HSIL from LSIL, will the size of the cell be smaller and in aggregates? Will it be smaller and isolated? Will it be larger and in aggregates, or will it be similar but more hypochromatic and in aggregates? Yes. We'll wait for the answers to come through.
Yep. We are getting answers as B.
Okay, so you think they're going to be smaller and isolated?
Yeah, B is so far the maximum, and some people have answered as A and C also.
Okay. So those who said A are on the right side. So when you move from, normally, when you kind of get more anaplastic, your cells get larger, more pleomorphic, but here your cells actually become smaller and you start seeing them in aggregates. Remember, when you see them isolated, as in B, you're actually, what are you saying? You're calling it as H, right? When you're getting a limited number of cells isolated with this kind of a morphology, you're calling it as H. When you start getting these cells in clusters, and these cells, they are small, but they have a very high nucleocytoplasmic ratio, you will not find collocytes so frequently here, but these cells look more like the parabasal cells, or sometimes you can confuse them with plastic cells. But then what you look at is the nuclei, and the nuclei will show you nuclear irregularity. They will show you coarse clumping of the chromatin, and they might show you some nuclear pleomorphism that may be present. And the cytoplasm you see is very green and dense. Okay, so this is, and still you can appreciate that there are these are looking somewhat scamoid because they have some pointed ends here, but they may be round. But this is like what the HSIL clusters will look like. Okay, so this is so the nuclei are going to be kind of large, but the cells are smaller and they will occur in clusters. And when these cells also start showing along with them a necrotic background, they start showing you sort of keratinization of cells which have got large enough nuclei. So they're not really, keratinization which is occurring with pycnosis like it would in a normal epithelium. So, and then you start seeing sort of these elongated cells, or what we call them as tadpole cells. So if you start seeing these abnormal shapes and sizes along with these dense clusters, which are showing you this HSIL kind of morphology, you know that you're looking at an invasive squamous cell carcinoma. Now coming to glandular abnormalities, in glandular abnormalities, you can get endocervical abnormalities, you can get endometrial abnormalities. It is not, when you're practically looking at the smear, it may sometimes be very difficult to say that this is endocervical or whether this is endometrial. So it is, you can say glandular cells, atypical glandular cells, or glandular malignancy without specifying whether this is endocervical or endometrial. When you're looking at the glandular atypical cells, again, you're going to find this kind of a high nucleoside ratio, and your clusters are going to be kind of tighter. They are going to be sort of more hyperchromatic. Again, here the cell of the nucleus size is going to increase. There will be overlapping of the nuclei, and as you go towards malignancy, there may be SNR formations also. So normal endocervical cells do not show SNR formations in clusters. If you're getting SNR formations in the clusters, you need to start suspecting malignancy with increase in nuclear size, with chromatin clumping, and sometimes rare nucleoli and mitosis may be evident in these clusters. So this would be an atypical feature. Again, you're seeing this sort of rosetting or SNR formation that is present. Wispy cytoplasm, which is kind of being thrown out towards the sides, and some kind of a tall columnar shape may be evident, especially at the periphery. And this kind of goes in favor of endocervical neoplasia. And as I told you earlier, tighter clusters, 3D clusters, and those clusters where it will be the nuclei are more rounded, would be favoring an endometrial type of carcinoma. So here you can see there's a lot of pseudostratification. There's a lot of overlap of the nuclei. There's kind of a clumping of the chromatin. You can appreciate almost like a tall columnar epithelium with these frayed margins that are present here, which suggests that you're looking at an endocervical adenocarcinoma, and you have sort of a glandular or a sort of I would say a core in the middle with these cells arranged around it, so which suggests that you're looking at an endocervical neoplasia. Again, here in endocervical neoplasias, you can get a discrepancy between the HPV testing and the cytology for two reasons. It may be because of false positive or a negative, false negative you may be getting, but the other reason also is that you have certain variants of endocervical carcinoma, like the gastric type, which are not associated with HPV. All right, so I think you will need to go back, and this is like a full lecture if you're going to do details of cytology. But we do get an idea from this presentation is that in screening, when you're using pap smears, you're going to be using the Bethesda categorization. In the Bethesda, you will look for cellular cytological abnormalities, which may be anywhere from atypia to in situ lesions to invasive lesions. So what is the implication? Suppose you're diagnosing LSIL in a woman between 30 to 64 years of age. Now, this is a chart which is given by Foxy, okay? So which is the Indian Association for Gynecologists, all right? So Federation of Obs and Gynae in India. So if you can see here, there is a solid line going on the left side and there's a dotted line going on the right side here. So the left side solid line is something that is preferred and the right side dotted line is something that is acceptable. Preferred is the HPV test, okay? And the preferred is the co-testing. But on the other side, acceptable is the colposcopy and the biopsy, and also acceptable is the via and the villi. We'll come to what that is. The only thing I want to point out here is that here there is sort of an acceptable compromise in which, maybe the HPV test, because it's a molecular test, it's not available everywhere. Number two is it is an expensive test. So in the Indian context, we are compromising to accept a method with a lower sense and spec in order to screen our patients. So that is a question mark that I want to. Then once you've reported an HSIL or you've reported an invasive malignancy, your patient will undergo a biopsy. So that is your second modality of screening, one could say, or maybe for confirmation of diagnosis. You can do a punch biopsy, you can do a cone biopsy, or you can do an endocervical curettage with a colposcopic visualization. The cone biopsy is an interesting specimen, which I would like to talk about a little to you right now. And it's very important that you orient your cone biopsy properly. If you receive an intact cone, you are that lucky pathologist. Please make sure that you mark the endocervical region separately with an ink and the ectocervical is on the other side. You will need to open up your cone, pin it up, and then fix it first in that pinned up way so that it's an opened up cone. And then you need to take entirely section that cone serially. And you can take 2 to 3 strips in every cassette. And you have to section it entirely and see whether you have clear margins in the cone or not. So again, emphasizing here, HPV can be a transient infection and it can be there for 6 to 8 months and it can disappear. So it is not necessary that every patient who's testing HR-HPV positive is going to have a malignancy. If this infection it persists for a long time, it will give rise to cytological atypia, it will give rise to precursor lesions, and then it may give rise to an invasive malignancy. So this is just a revision. These squamous intraepithelial lesions can be either conventional classic pattern, as we have seen, or sometimes you can get other patterns like a thin HSIL, which is less than 10 cells thick, but then these cells are going to look like really, dysplastic. Sometimes they can mimic atrophy, but there will be a lot of dysplasia and a lot of nuclear pleomorphism, which will be present in these thin layer of epithelium. Again, an intraepithelial lesion, which you have to report as high grade. It can sometimes be keratinizing with a superficial keratinization of polycytosis and a basal layer showing you those classical changes. It can sometimes be even papillary in configuration, or it can sometimes be very bizarre and pleomorphic, but it will remain confined. When confined to the epithelium, you will still call it as an HSIL. Sometimes life can be difficult. You're looking at some changes. There's a lot of inflammation below. You think, is this atypia? Is this just reactive? Or is this actually, the beginning of a malignancy? Is this a precursor lesion? So if you run a P16, and if you get a block positivity for P16, especially in the region, like in CIN1, in the lower half of the epithelium, or in the full thickness of the epithelium in cases of higher grade lesions, it can help you to give a diagnosis. Also, people have said that Ki67 can help. So this is the kind of block positivity for P16 in some of our cases, and you can see that the entire epithelium gets stained if you're looking at a dysplastic lesion. So the other thing you can also do is a direct in situ hybridization for the HPV RNA, and then you can actually prove that the HPV is present there. Again, you have to understand that all these techniques have their own sensitivity and specificity, and you may not get it positive in all the cases, even though the lesion may be present. So earlier you had the CIN 1, 2, and 3, but as I told you, it is better that you categorize your lesions into either a low-grade lesion or a high-grade lesion. And as far as your infection is initially latent, and as soon as it becomes a permissive infection, transforming infections occur, and then you get the beginning of a malignancy. The other thing you can also do is a Ki, and you can appreciate that your Ki will be kind of really high, and your Ki staining will go right up to the top in some cases. And we have also used this P16 P16 and Ki in our studies quite some time back actually on LBC smears, and you can see that the P16 expression is present also in the smears, and this can help you to demarcate malignant cells and reconfirm them. And there are now also kits available which do both the Ki and the P16 together, and if you put that onto a slide, maybe that can help you to do better. But nothing like a good cytology, a good smear, a good collection, and I think the sense and spec is good enough if you're collecting well and screening well most of your smears. And just showing you here one of our works which we also published, and this was a poster presentation. And what we also tried to do there was, the aneuploidy studies. So because it was a liquid-based cytology collection quite some time back, and so we also did ploidy studies in flow cytometry to see, whether aneuploid cells can help us to make a diagnosis. But believe me, using all these techniques like the P16, the Ki, and adding the aneuploidy studies doesn't really bring up your sensitivity too much, and it's just like a lot of expenditure. I would suggest it's better to add your HRHPV. Also, with the pap smears, you need to understand that this is a very labor-intense method, and to screen a smear, ideally a pathologist would take anywhere between 5 to 6 minutes. So the number of smears that can be stained by pathologists cannot be very high per day, and therefore there is also a thing that you train your cytotechnologists in order to screen the smears, and the ones in which they are doubtful can be the ones which can be put up before a pathologist. So that was also a modality of doing mass screening. And then we also kind of Dr. Rajan, they were at the Ann Arbor, actually started making these massive online courses for PAPs, how to examine PAP smears, and I was part of his group where we were recording these MOOCs for screening of PAPs. That was also quite some time back before the HRHPV test hadn't made it big. So what's next? I mean, as I told you earlier, you have these pathways. We have talked about the cytology pathway. What is there next available? We can do the HPV screening and we can do the co-test. Let's go through the HPV screening. The HPV screening has been recommended by the American Cancer Society, and they have kind of put the start age at 25. And if it is a negative test, you need to repeat it every 5 years. What do you test for? You test for the high risk HPVs. How do you test for them? You can look for, so these are the high risk HPVs that you need to test for. And as I told you earlier, these can be group A or group 2A and group 2B. You can ask me, why are you dividing them up like this? The reason being that when you look at the group A, you have your 16 there. And if you look at the persistence of the 16 and the 58 is highest. And the development of CIN3 in the 16 and the 58 is highest. In the other group, as you can see here, 18 has the highest persistence and the highest development of CIN3. And then in the group 2B, you can see here that 51 has the highest development of C3. So if you know which HRHPV is infecting the patient, you know what is the risk of, what is the higher risk of developing CIN3 in this patient. So that I would say would be highest for a person with a 16 HRHPV type 16. As I said, the basis of the test can be many viral targets, which can be either your E67 proteins, they can be the late structural proteins, they can be long control region, and you have various testing platforms. Now, this is again another thing that you should understand these testing platforms before you use them. Also, some of these testing platforms are approved for co-testing. Very few testing platforms are approved only for primary screening for HPV. The Roche Cobas platform is the first one which was implemented for primary HPV screening. This is the one that we have, and this was kind of validated through the Athena trial. Those of you interested in more details, you can go through the Athena trial and see what are the drawbacks of this trial. I will touch a few points later. But when they compared this Cobas candidate with the hybrid capture, which was there earlier, they saw that this had a higher sensitivity, and cytology had a higher specificity. But the negative predictive value of all these tests was fairly good, and that's what we are looking for when we are using a test for screening. The FDA-approved HPV platforms as of now are the Hybrid Capture 2, the Cervista, the Aptima, the Cobas, and the BD on Clarity, which just came up lately. Now, when you compare these platforms, I mean, this is it might be getting too much into details for you, but I think one should know what one is getting into. And I would like to inform you here is that the Cobas platform and the BD on Clarity are the ones which are approved for primary screening. Also, when you're looking to use a platform, you need to understand whether this platform has a built-in control. And can you see here is that yes, there are controls here in the Cervista, in the Cobas, you have none in the Hybrid Capture, and you have also the beta globin in the BD on Clarity. And the only platform which actually has an HRHPV transcript as a control is the Aptima platform. The trends in usage of these 4 platforms, as you can see, that the Cervista, which is the hybrid capture based one, and also both the hybrid capture based ones, they have gone down. Whereas the one which is based on the Cobas is based basically on a PCR reaction, and so is this one, the Aptima, which is based on the detection of the proteins of the RNA. So this is like these two, the usage of these platforms, it has gone up. There are several other platforms available. I don't want to bias you. So there are, what we are talking about is FDA, but there are also CE marked platforms. So a whole lot of them, not many of them are available in India, but like the BD on Clarity is also on the CE as well as on the FDA, and so is the Cobas platform. And then you have several others. So you have choices. You need to look at is, the sense and spec of that platform, its applicability for primary screening, the presence of built-in controls, and the methodology on which the platform is based before you decide which platform to use. Coming to that, back to that, the HPV test and the problems with the HPV test are that you can have a certain percentage of cancers which are not HPV associated. For example, the Milan study gave these at 4.2, and some people have given these percentage to be as high as 15, as these two studies are showing. And the Quest study actually put this as 18% for squamous cancers and 26% for adenocarcinomas. So coming back to our poll question, which of the following is a possible reason for a false negative HPV test? If the patient has an HPV vaccination, is the specimen inadequate when inhibiting factors or a poor quality target DNA, or is it an HPV negative cervical cancer? Or is there a very high copy number, or there are multiple infections present? When will you get a false negative HPV test?
We are getting answers as option B.
So absolutely right. The option B is the right answer. So in an HPV vaccinated person, you would not expect a false negative HPV test, because if there is a malignancy there, the vaccination can cover certain, like if you have a bivalent vaccine, it's covering 16, 18, maybe you get the other HRHPV, you have a quadrivalent vaccine, you have a nanovalent vaccine, but it doesn't cover all. So it's quite possible to still get alternative HRHPV infections. The HPV negative cervical cancer would not be called as a false negative, that would be a true negative. And it's not a high copy number, but a low copy number, which usually results in a false negative HPV test. So these are the etiology of a false negative and a true negative test. So true negatives, I would like to emphasize that, if the population has been taking vaccination for a long time, it's quite possible that the HPV associated malignancies are not occurring, and what you're getting in the cervical cancer as cancer cervix may be non-HPV associated. So that fraction which will go up, the non-HPV associated ones, as we go in deeper into the vaccination program, and late you have started it early, and you have now those vaccinated girls who are coming into the 30s and 40s. That's one thing about cervical cancer. Actually, it affects females in their productive years of life. I would say in their giving years of life, and therefore it actually affects full families when these patients they are affected by this cancer. So primary HPV testing is this the new ASQS. So if you get a positive HPV, it doesn't necessarily mean that the patient has got a malignancy, and then I guess it would be reflex in the other direction when you get a positive HPV, and then the patient goes either for a pap smear or a colposcopy. And this a lot of HR HPV testing has actually loaded the colposcopy clinics, and maybe there's some kind of an over treatment that is going on. The global strategy says by 2030 we have to do like a 90-70-90 target, which means that 90% of the girls need to be vaccinated, 70% of the women need to be screened at least twice, and 90% of the women who are identified with the disease should undergo treatment. So what are we doing to actually implement this target? The other thing that has come up for HPV testing is the self-collection. Now, you will realize, for those of you who are women in the audience, that when you are actually, theoretically that this test is required and you need to go get a pap smear or go and get an HPV testing done, but you don't really land up in the hospital for various reasons. You just either keep postponing it. There's no pressure on you to actually get it done. Maybe you're too scared. If I go there, something comes out, for various reasons. But if I give you a brush and I say you collect the sample and you drop it here at the, anywhere, or you collect it from you at home, maybe your compliance rates will go up. So people have now come up with this self-collection model for HPV testing. And we are currently running a project from Chicago wherein, they are actually, we've collaborated with them, and they are kind of covering using this WHO goal where you have to cover 90% of the population, screen 70 at least twice, and then treat 90% of them. For so in this Raniganj Jagdishpur, what we are trying to do is cover all 5,000 women who live in that area. They're being approached by ASHA workers. They are being counseled and invited. They're provided with vials and kits. They collect their own samples. They are taught how to collect them. They are collected at the local center. They come to us for HRHPV testing in our Molpath lab, and then those which are HRHPV positive, they undergo a pap smear and a colposcopy. So it's actually interesting, but we found like our incidence there is almost like 7 to 8%, and whatever number of women we have screened so far having an HPV positivity. So HRHPV testing can be actually a good way with a self-collection model. What we're trying to establish is whether this model can be duplicated in centers in similar CHCs, and this kind of a WHO target can be met. So we have talked about so far of screening cases where we do not know that they have cancer. But what about the patients who have undergone treatment for CIN, maybe a cryo treatment or maybe a bone biopsy? What do we need to do for these patients? Just one slide on that. We need to do like a 6-month follow-up, and the cytology should be repeated, the HRHPV testing should be repeated, and in case of an HPV test cure, which means that if the patient becomes HPV negative, then you can kind of do a follow-up at 1 year, and after that, you can keep following up that patient with PAP and HRHPV screening. So summarizing, the FDA approved HPV screening acceptable methods after the are kind of acceptable for screening, and you should be using basically methods which are approved for primary screening. And despite the appeal of primary HPV screening, several issues are unresolved. One is that you have HPV negative cancers, and second is the expense of the test is kind of really high, and third is that you might be doing some kind of a report like an ASQS, as I said earlier, and all cases which are HPV positive are not going to be having the cancer, so they will require subsequent testing. And just a few slides in the end about what is villi. This is not really what the pathologists do, but then this is another methodology of screening for cervical cancer. So either you can paint the cervix with iodine, or you can paint with acetic acid. The malignant areas show up as acido-white areas, and in the iodine they will actually not take the iodine, and these areas can either they can be what the government of India has now actually started at a lot of centers is what is known as a see and treat program, in which you do the via and the villi. If you find these suspicious areas, at that point only they use either a leap or a loop or a cryo to kind of remove these areas from the cervix, and this would be like you see, you diagnose and you treat. The obvious problems with this is that you might be over diagnosing the cases, you might be over treating, but then this is a program which has been given a thumbs up and it is implemented, but there is a switch somehow to the HPV also trying to happen. Some people have come up with sort of these card tests which give you an HPV result also in a short time. Those card tests are not validated, they are not for use in the clinics, but the point is that maybe in the future we come up with some test like that which can immediately give a result, because you have to understand that when you're doing, so these are the treatment modalities as I've already told you, when you're doing this kind of HPV screening, the cervical cancer screening, the problem is the loss to follow up. Okay, so and so that loss to follow up doesn't happen if you can do it in a one sitting itself. Coming to the prevention of the vaccines which are available are all these listed here. As I told you earlier, they may be a bivalent vaccine. Obviously, bivalent is not something that you want to use as of now. What the basic you're using right now is a quadrivalent vaccine. You have the pentavalent, and you also have the monovalent vaccine, which is again coming from Gardasil. Now, Cervavac is the first made in India vaccine, which is made by the Serum Institute. Initially, when they announced it, there was a happy feeling, and we thought maybe this is going to be a cheap vaccine, and we might be able to implement it in a prevention program in India for all the patients. But unfortunately, when they rolled out the vaccine landed up to have a cost of one dose to be 2,000 and the 2-dose vial to be 4,000. So we are really not looking at a cheap vaccine here to be implemented entirely for the national prevention of cervical cancer. When we look at the screening programs in other Asian countries, India and Indonesia mainly use this VI and VILI and the see and treat strategy. And I also need to say here that this is a strategy used by Sub-Saharan Africa. So I personally feel that maybe we should evolve, maybe we should go beyond. And this slide basically shows you the tracking of women. This is a US-based slide. So if you can see here, if you're looking at 30 of 1,000 target women in which you think that HSIL may be present, actually 18 turn up for the pap smear, 13 have their slides read at the lab, 12 receive the lab results, 7 out of them return for their diagnosis, 6 out of them who present with their diagnosis to the clinician, 5 out of them receive the treatment, and 4 are successfully treated. So you can see even in a very elaborate setup, in a very resource-intense setup, this kind of a screening where you are kind of losing patients at every step, and hence this see and screen strategy probably was implemented, but we still need to know how effective this is going to be and how, and plus the penetration of the program is very low. Only 5%, less than 5% of the population is covered, that too, how much we don't know. So what would be a cost effective? I just need to read out the figure in the end, that anywhere like a rupees 800 approximately or a 10 USD would be something that would be cost effective as far as the Indian control strategy is concerned. So when our vaccine and when our screening strategy, when our HPV DNA testing is going to come within that bracket, is probably when the government will be able to implement this program and actually be able to screen what we are talking about, the 70% screening at least twice as far as the WHO strategy is concerned. And just coming back finally to my last slide with the key messages, in the high income countries, cervical cancer incidence has sharply declined, and this is probably due to the widespread screening and the treatment of precancerous lesions and basic cancer and the improved socioeconomic status. Cervical cancer is highly preventable. HPV vaccination should be given to all girls between 9 to 12 years, where 2 doses are given, and maybe given at higher ages also in the teenage, or if you are HPV negative, when 3 doses are given. The primary HPV screening is a practical, effective method for screening, but it's costly and will also overload your colposcopy clinics. The cytology-based screening programs may be unsuitable in lower income countries because of the less number of doctors that are available, less number of trained staff, and the hospital-based triage may be only ideal for a where a co-testing is done, may be ideal only in hospital-based conditions. The studies using VI and VLI screening and the treatment programs suggest reductions in incidence, but scaling up these programs, sustaining these programs in routine health services is a challenge. And HPV testing shows great promise, but is expensive. So what we need basically is a cost-effective HPV test. And I finish with investing in the health of girls and women is an investment in the development of nations and their futures. Let us explore ways to lessen the divide between the lower and middle income countries and the high income countries, especially for screening of cervical cancer. Thank you.
Thank you so much, ma'am, for highlighting all the practical aspects and also the challenges which are faced while screening the cervical cancer. So I would like to invite our chairperson for any inputs from her side. Sneha, madam.
Yeah. Ma'am, that was a really elaborate and comprehensive lecture. You have covered all the things about cervical cancer screening, and there's really not much left for me to say. Just a few clinical things. That cervical cancer is indeed, India is facing a very high burden of cervical cancer. And it is a shame because it is a cancer which has the potential to be eliminated. And there we can prevent it. It can be prevented by primary prevention, secondary prevention, and tertiary prevention is nothing but tertiary prevention is to detect it at early stages to decrease the mortality. And primary prevention, like what Madam said, is by using HPV vaccine. India rolled out HPV vaccine quite early, around in 2000s, but then there were a lot of controversies when the HPV vaccine was rolled out, and there were deaths of few girls, and there was a large misconception among the general public that these deaths were because of the HPV vaccine. There was less government support at that point of time, and that is why India could not include the HPV vaccine into the national immunization schedule. So we have come a long way, and now the government is actually making efforts to include the HPV vaccination into the national immunization schedule, and I hope it will happen soon, but the cost still remains an issue. So we need to see how to work our way around that. And secondary prevention, yes, India still depends on visual inspection of acetic acid as its main screening modality, because Madam quoted a figure that only 5% of our targetable aged population have been screened. So if we, at this point, only 5% of women who are eligible to undergo screening for cervical cancer have been screened. And that is largely because of hesitation among women to get screened for this cancer and also lack of resources. And visual inspection of acetic acid is very easy to perform. It's mainly performed by paramedical professionals who are mostly ASHA workers and nurses, midwives and nurses. So they just need to be trained for 2 to 4 weeks, and they can go into the general population, into rural areas, and conduct screening. So India still heavily depends on visual inspection of acetic acid at this point of time. In higher centers, yes, like Tata Memorial Hospital, we do screening with pap smear, and we also use HPV testing. We use the hybrid capture 2 assay to perform the HPV testing. And yes, coming to CIN, it's CIN1. The Indian guidelines, the FOXY guidelines, they recommend pap smear testing from the age of 25 years and HPV testing starting from the age of 30 years, because they say that before the age of 30 years, because women are at the peak of their sexual activity, doing a HPV testing before the age of 30 years, almost every woman would come positive, because it's such a common sexually transmitted illness, and we don't have to jump in and treat any woman who tests positive for HPV. So these are what the Indian guidelines say. And right now, coming to the treatment of pre-invasive lesions of the cervix, CIN1 usually doesn't warrant any treatment. We just follow a wait and watch policy for CIN1. And when it comes to CIN3, we would always be very cautious. We would go ahead and treat this lady. And when we get a report of CIN3, we would always want to rule out an invasive cervical cancer. So we would generally do a leap to rule out an invasive cervical cancer. The main reason being the treatment of these two, the treatment of CIN3 versus the treatment of an invasive cervical cancer is different. That is a simple hysterectomy versus a type 2 or a type 3 radical hysterectomy. And a simple hysterectomy has very less complications, postoperative complications like urologic complications compared to a radical hysterectomy. So I guess that's about it from me. And thank you so much, madam. It was a very informative lecture. I'm sure the students would have understood a lot about this. It's a complicated topic for clinicians, but I guess the patho students would have, they would have benefited a lot. Thank you so much.
Thank you. That was wonderful. Yeah, great inputs. Thank you. Thanks, Neha.
Regarding the questions, ma'am, I think you have addressed both the questions. So, yeah. So in transitional cell, incidence of which carcinoma is more squamous or glandular?
So classically, we examine this region for squamous intraepithelial neoplasia, because this is a region where you get squamous metaplasia, and you must have also seen in most of your slides. they have a tendency to kind of undergo neoplastic transformation. So that's a region where you might find squamous, but this region classically has both types of malignancies, I mean, in my experience. So you can also get glandular malignancies at that site.
Right, ma'am. So that's
Thought
all.
disturbing here. I would want to log off.
Yeah,
Thank you
sure.
for having me as the chairperson.
Yeah.
But thank you so much.
Thank you
Have
so
a safe flight and a good trip. Yeah.
Thank you so much.
Bye-bye.
Bye.
I mean, the chat box also audience is thanking you for a very crisp, informative talk. Thank you so much,
My
ma'am.
pleasure, absolutely. Thank you.
So I will just share my screen to show our next